Good morning, everyone. My name is Ada, and I completed my practicum with the BC Center for Disease Control. I would like to thank Dr. Navid Janjua and Dr. Prince Adu, as well as Research Coordinator Georgine Gower and other members of the BC CDC Data and Analytics Services for all their support throughout my practicum. I also noted my partner here, so I also want to thank them for their support throughout my program because it wasn't an easy journey. The data and analytics team work collaboratively to build capacity to support innovation and population health solutions in the province. And it was such a privilege and humbling experience to engage with the team and learn directly from public health leaders who have similar interests and goals. Before I begin my presentation, I would like to respectfully acknowledge the Lakwangan speaking peoples on whose traditional territory the university stands, also where I completed my practicum. Just a little background and context for my presentation. As we all know, as of January 2023, COVID-19 had led to over 6 million deaths recorded worldwide, making it a public health issue. Individuals with pre-existing illnesses and comorbidities, such as cirrhosis, may experience more severe outcomes, posing a major health threat to these individuals. Cirrhosis is a chronic liver disease that is categorized by scarring of the liver and typically occurs at the end stage of most liver diseases. Studies have found that individuals with cirrhosis who contract COVID-19 are more likely to require hospitalization and intensive care, and they may have higher risk of death compared to those without cirrhosis. From conducting a literature review in collaboration with our MPH librarian, I found that individuals with cirrhosis who have decompensated cirrhosis, which means when the liver is no longer able to function properly, may be at even greater or higher risk of severe illness and complications for COVID-19. The complexities associated with COVID-19 severe outcomes, cirrhosis, and other intersecting factors such as older age, sex, race, vaccination status, and etc., often exacerbate the severe outcomes of COVID-19. The objective of my project was to develop a manuscript for publication that reports the assessed risk of COVID-19 severe outcomes, particularly ICU admission among people with cirrhosis in BC. And I did this by analyzing the data retrieved from the BCC19C, interpreting the results, and providing recommendations to support public health measures. To focus a little bit on cirrhosis for this project is due to a couple of factors. From my research, I found that there are limited evidence specific to cirrhosis and COVID-19 severe outcomes. Also, the team focuses a lot on projects related to liver conditions, so hence the focus on cirrhosis. Just a little bit about the method I used to approach this manuscript today, or during my practicum. So the BC COVID-19 cohort, also known as BCC19C, is a population-based cohort that integrates data on all lab-confirmed COVID-19 cases with data on hospitalizations, medical visits, emergency room visits, prescription drugs, chronic conditions, and other data as shown on the slide. All individuals aged 18 or above who tested positive for SARS-CoV-2 by real-time reverse transcription polymerase chain reaction from January 1st, 2021, which was the initial start of the vaccination program, to December 31st, 2021. They were all included in the analysis. The BCC19C is a collaboration between PHSA, BCCDC, and the Ministry of Health. And the primary purpose of this particular study is to support the surveillance and emerging questions particular to COVID-19 in the province. To the best of my knowledge, this study is the first population-based cohort study to assess COVID-19 severe outcomes among individuals with cirrhosis in Canada. And just a quick summary of the results I found that ICU admission is a severe COVID-19 outcome that significantly affects people with cirrhosis in BC. For example, I found that cirrhosis was associated with 187% increase in ICU admission compared to those without cirrhosis. In addition, I also found that overall male sex, older age, those with lower income levels, vaccination status, and people living in northern BC were mostly impacted by COVID-19. For example, those living in northern BC presented a 76% increase in ICU admissions compared to people living in other regions. Compared to females, The male sex had the highest magnitude of association with ICU admission across all age groups and irrespective of the vaccination status. I also found that the odds of ICU admission decreased with an increase in income level. Overall, though, older age had the strongest association with ICU admission, and I found that irrespective of vaccination status, cirrhosis was still associated with ICU admission. However, being vaccinated reduced the risk of ICU admission for patients with cirrhosis by 89%. These findings provide strong evidence that existing health disparities and health inequities extend to disparities in COVID-19 severe outcomes, which should be considered by policymakers, healthcare professionals, researchers, especially when thinking of planning for future pandemic-like emergency responses. It was very particular to be able to capture such vital information as one of the priorities I had throughout my practicum project was always keeping in mind an intersectional framework and being able to identify health disparities that come up or using data to kind of identify those particular disparities. Considering these complexities, as I mentioned earlier, I applied the intersectional theory, which can help identify and better understand how disparities such as age, income, geographical location, and pre-existing comorbidities affect populations. Based on my findings from the study, I offer the following recommendations to strengthen public health practice for people living with cirrhosis in BC. First of all, public health professionals and policymakers should take action to advance health equity by identifying existing health disparities and their implications for reproducing and exacerbating poorer health outcomes. Policymakers also should develop policies in consultation with communities to collect race-based data and other individual characteristics as part of the administrative health data. An example of this is with the BC Anti-Racism Data Act, which became law on June 2nd, 2022, and co-developed with Indigenous peoples and racialized communities. This legislation is the first step of many to collect and use data to help tackle racism. And lastly, just to suggesting or recommending that as public health professionals, we develop targeted interventions that are aimed at protecting individuals with cirrhosis from COVID-19 and future viral infections. But we also want to prioritize the specific interventions such as vaccination, especially for high-risk populations like Indigenous and racialized communities, people with low income, older populations, and those who identify as male. A major strength of this study is this large sample size. A total of 509 individuals were included in the analysis. And this helps me with the overall representativeness and generalizability of these findings. Another strength of this study is that by using administrative health data, I was able to access information on income level and health authority, which helps us identify again those social determinants of health that are particular to this population. This findings should be interpreted with the following limitations in mind though. First, since using administrative health data often lacks additional information on clinical diseases of interest and health outcomes and other social determinants of health like race-based data and other confounders, it is important that we keep this in mind as we move forward. In conclusion, the complexities around COVID-19 cirrhosis and the associated risk factors require researchers and epidemiologists to incorporate a lens or approach to research and data analysis that appropriately considers the implication of health disparities and also intersects their challenges to create sustainable and equitable public health prevention strategies. Thank you. And to conclude my presentation, like I mentioned earlier, I'd like to thank Dr. Navi Janjua, Dr. Prince Adu, Georgine Gao, Dr. Jeff Masuda, and the entire University of Victoria, as well as my peers who were incredibly supportive throughout the program. It's so exciting to be done. And also just a big shout out to Celeste and Melissa. Celeste particularly for helping me review my project. It was very, very helpful. And Melissa, thank you so much. That ends my presentation. Thank you.